Hello, my name is Siddharth and my topic is ultrasound guided lumbar plexus block. The lumbar plexus is formed by the union of the anterior primary rami of L1, L2, and L3 and the greater part of L4 within the substance of the psoas muscle. It also receives variable contribution from T12, subcostal nerve, and L5. However, the lumbar plexus is located within the substance of the psoas muscle and local anesthetic is injected into a fascial plane within the posterior aspect of the psoas muscle. Lumbar plexus block produces anesthesia of the major components of the ipsilateral lumbar plexus, the femoral nerve, lateral femoral cutaneous nerve, and the obturator nerve. It is also referred to as psoas compartment block or posterior lumbar plexus block. The term PCB was originally coined by Cheyenne and colleagues. They believed that branches of the lumbar plexus and parts of the sacral plexus were located close to each other in a compartment between the psoas major and quadratus lumborum muscles at the level of the L4 vertebral, and could be identified using loss of resistance. The anterior boundary of the fascial plane that contains the lumbar plexus is formed by the fascia between the anterior 2/3 of the compartment of the psoas muscle that originates from the anterolateral aspect of the vertebral body and the posterior 1/3 of the muscle that originates from the anterior aspect of the transverse processes. This arrangement explains why the transverse processes are closely related to the plexus and therefore are used as the main landmark. Lumbar plexus block is the most proximal approach and reliable too. It is used for hip and above knee surgeries. Along with sciatic nerve block, it provides complete unilateral lower limb anesthesia. The usual machine setting is curvilinear probe and abdomen region preset, depth setting 6-9 cm using 10 cm short bevel needle within plane approach using dose 15-20 ml of local anesthetic drug. The authors prefer to position the patient in the lateral position with the side to be blocked uppermost. The hips and knees of the patient are also flexed to mimic the position normally adapted during an LPB. The ultrasound scan can also be performed with the patient in the prone position, but the disadvantage is impaired visualization of the quadriceps muscle contraction during an LPB if nerve stimulation is used. Patient is placed laterally with hip and knee flexed, and skin marking is done like A. Midline, B. Intercrystal line, C. Sagittal scan line, X. A 0.4 cm from the midline along the intercrystal line. Sagittal scan is performed at line C. Transverse scan is performed on line B, above the line C, and on point X. Point X is the entry point for needle insertion for all approaches. First approach, paramedian sagittal scan of the lumbar paravertebral region. In this approach, the ultrasound transducer with its orientation marker directed cranially is placed over the sagittal scan line, which is a line 4 cm lateral and parallel to the midline, at the level of the iliac crest. In this sagittal approach of the lumbar paravertebral region, the lumbar plexus appears as a hyperachoic structure in the posterior aspect of the psoas muscle between the L4 and L5 transverse processes. Also note the hyperachoic intramuscular tendons within the substance of the muscle. The acoustic shadows of the lumbar transverse processes, L3, L4, and L5, produce a sonographic pattern called the trident sign. Second approach is paramedian transverse oblique scan of the lumbar paravertebral region. In this approach, the ultrasound transducer is placed lateral to the sagittal scan line and over the intercrystal line with its orientation marker directed laterally, outward. Also note the transducer is angled medially for the ultrasound scan. At the level of transverse process, the acoustic shadow of the transverse process obscures the posterior part of the psoas muscle in this approach. So, the transducer is kept through the space between two adjacent transverse processes to view the lumbar plexus in the posterior part of the psoas muscle as a hyperachoic structure. C. In this approach, the lumbar nerve root is seen emerging from the intervertebral foramen, and the lumbar plexus, hyperachoic, is located within a hypochoic space, psoas compartment, in the posterior aspect of the psoas muscle. Also note the lower pole of the right kidney is seen anterior to the psoas muscle in this sonogram. Approach 3 Shamrock Method. In this approach, transverse sonogram of the lumbar paravertebral area obtained at the level of the transverse process of the L4 vertebra. the anatomical arrangement of the three muscles around the transverse process, that is, the psoas muscle lying anterior, the erector spinae muscle lying posterior, and the quadratus lumborum muscle lying at the apex, produces a sonographic pattern that has been likened to a shamrock, with the muscles representing its three leaves. See, this transverse sonogram of the lumbar paravertebral area obtained with the Shamrock method at the level of the transverse process of the L4 vertebra, showing the prominent transverse process and the arrangement of the psoas major, PM, quadratus lumborum, QLM, and erector spine, SM, muscles around the transverse process, that has been likened to a shamrock. The lumbar nerve root is visualized close to the angle between the vertebral body and the transverse process, and the lumbar plexus within the posterior aspect of the psoas muscle, typically about 2 cm anterior to the transverse process. From this position, if the transducer is gently tilted caudally, the acoustic shadow of the L4 transverse process disappears, and the ultrasound beam is now insulated through the intertransverse space, and at the level of the articular process of L4 vertebra. In the resultant sonogram, the psoas, erector spinae and quadratus lumborum muscles, the intervertebral foramen, and lumbar plexus are now clearly visualized. Let's check out real screening. Let's have some real lumbar plexus block. Block video 2. Let's check out some clinical pearls. This block is advanced block having major complications. This is a highly vascular space, so two major problems. 1. More absorption of local anesthetics leading potentially high plasma levels, and 2. Coagulopathy is a contraindication. Technical difficulties because of tissue contrast changes are there with specific population like elders, obese, and patients with high pelvic arch. Some clinical variations in position of obturator nerve, like it may lie in a separate intramuscular fold or in a compartment separate from the SOS compartment. However, position of lateral femoral cutaneous nerve and femoral nerve are fairly consistent. Many, including me, believes that it is the only block which requires PNS, and second thing, that syringe should not be attached to needle while performing block. Thank you very much for your kind attention.